like to thank you for attending our physician lecture. This is Dr. McNab, and he's going to talk to us today about H&Ts of ACLS and PEA. So I'll turn it over to him. I will say that at the end, when there's questions, if you would give us a minute to kind of come around to you with the microphone. As you can see, we're video recording this session, and everyone would like to hear your question and then the answer that you received. So thank you again, and I will turn it over to Dr. McNab.
Cool. Well, good morning, everybody, and thanks for having me out. I think this is my third or fourth one of these nursing lectures. This is kind of a trifecta for me this morning because I've got two groups of people that I really enjoy working with, the nursing staff and then the medical student staff, all in the same room. And I get to talk about a topic that I think is fascinating and really interesting. So it doesn't get better than that at 7:30 in the morning. So thanks for allowing me that. And again, I always start these things with a thank you to the nursing staff. I'm really a big fan of your guys' work. So I feel like this is my way to give back to the nursing staff. So I appreciate everything that you guys do. So this is a disclaimer slide. Apparently I have no financial relationships with the American Heart Association or anybody who makes amiodarone or takes care of people with codes. So today the topic is pulseless electrical activity. And then to just clarify something that Angie said, I'm really not going to focus on the H&Ts. I think that that's part of the problem of PEA, is that it's too clunky for us to, in the middle of a code, stop and think about these long lists of things. So what I'm going to try to do with this lecture is I'm going to try to provide you guys with some common sense approach to a really complicated, really serious process, and hopefully a lot of these mental tools are going to really help us out in the middle of these codes. So I always like to start with the statistics, because the thing is, I want to impress upon us that this is really important. You know, I don't want to waste your guys' time with trivia and mundanity. I think that 1,700,000 deaths in 1 year from cardiac arrest, that number tells me we should take this extremely seriously. And the fact that by 2030, all of these really rapidly aging baby boomers are going to push those numbers up to 23 million cardiac arrests per year. That is globally, of course. That means that we're going to get a lot of opportunities for us to practice our code blues, right? And apparently 23 million opportunities a year. As you can see from this slide from the American Heart Association, if you come in with a code, all comers, no matter what type of code we're talking about, you've probably got about an 11% chance of surviving that code, all comers. When you look at shockable rhythms, then our survival rates go up to about 31%. So it's important to keep that in mind. We like shockable rhythms, and if you don't have a shockable rhythm, boy, our success rate just kind of gets cut by 2/3. So when we think about major codes at Freeman, we can divide that up into these algorithms: unstable VTAC, VFib, PEA, and asystole. And I think that you guys probably can tell by looking at this slide that we really want VTAC and we want VFib. Give me a 65-70% success rate, boy, I feel great about that. I love finding patients in unstable VTAC. I just don't find it as often as I would like to. But when you get into PEA or asystole, these patients have a much worse survival rate. Asystole is just the worst. You have almost no chance at all to bring those patients back. So keep these things in mind. You know, we all get emotionally attached to these codes and the outcomes of them. But know that when you go into the door, if you've got a 98% chance of failure, you really don't have to feel too bad about when the obvious outcome happens. Keep this in mind. Know what you're up against. Okay, so like I said before, VTAC and VFib, this is what I love to see when the code blue button gets pushed. PEA and asystoles, I really dread walking into those rooms because they just don't give me the outcomes that I would like to see. So let's take a second and just talk about what should be happening. So if your SA node and your AV node, these are our electrical pulse generators of our heart, are doing their job, then we should take electrolyte chemical signal, process that into an electrical output, and that electrical output should hit our heart, run through our cardiac nervous system, our Purkinje fibers and the bundle of His, and if these things happen, if that electrical signal makes it to our heart, if this myocardium is functional, it's got all the oxygen, it's got all the glucose, it's got all the ATP that it needs, and blood could actually get into that heart, and blood could actually get out of that heart. If you got all of those things, electricity, functioning muscle, and an inflow and an outflow tract, then we can have a pulse and a blood pressure. So we need to have all of those things to make the cardiac cycle work for us. And this is where PEA gets really interesting. So anything that deranges those functions can stop that process. Cardiovascular problems like a myocardial infarction or toxicity to the heart, big time pulmonary problems that cause hypoxia or obstruction to the blood flow to your lungs, metabolic derangements that screw up the electrolyte functioning that affects how the heart depolarizes and handles calcium. Any of those things are fair game to cause pulseless electrical activity. And I guess before I go any further, is everybody in the room ACLS certified? So when we talk about like PEA, pulseless electrical activity, or electrical mechanical disjunction, if you're old enough to remember that term, we know what we're talking about then. So we're making, the electricity is flowing, but so we got a starter, but the engine's not turning over for some reason. Basically, that's what PEA is all about. So look at this slide. I think that this is fascinating. Look how simple this algorithm is. It's a three-stepper. What do you guys think is the most complicated thing on this algorithm right here? What makes this so simple algorithm so darn difficult? Anybody want to hazard a guess? I'll give you a couple seconds to be brave. No? Nobody? All right. I'm going to tell you what I think is the hardest part about this. It's right here. Treat reversible causes. The rest of this is easy. We're smart enough to identify VVIB and VTAC and shock it if we see it. That's easy. Any of us can give epinephrine every 3 to 5 minutes, and we're all pretty good at cardiac stimulation. So CPR is not that big a deal. But what I think is very interesting, when I run to these codes and the adrenaline is up and everybody's doing their best and we're all on edge, it's hard to stop and think about, well, what are the potentially treatable causes? And that's where, if you want to have a chance at that 11% save, you've got to address this. Treat the reversible causes. This is your patient's only chance at success. Doing as much CPR as you want, giving epinephrine is not what saves these patients' lives. And it's hard to do that in the middle of a very stressful code event. So, for the past 20 or 30 years, when we get to the PEA algorithm, we get to talk about the 5 H's and the 5 T's. And I know everybody in this room has seen them. And initially when I was thinking about doing this lecture, what I was going to do is I was going to show you this slide for about 5 or 6 or 7 or 10 seconds like I just have, and then I was going to click away from it, and then I was going to drag some poor unsuspecting victim up here, put him in front of the class, which would be kind of stressful, and say, could you just repeat back those 5 H's and 5 T's that I just showed you for 10 seconds? So you're prepped, you know, you're just like you studied for the test, you're ready to go, put you under a little bit of stress, and let's see what happens. And then I thought, well, that would be, this is being videotaped, that would be pretty obvious cruelty on my part. So we're not going to do that. But I think you guys get the point that pretty good chance, once I make you nervous and put you in front of our peers, we're probably going to miss a couple of those H's and T's, right? That just makes good sense. I think I would too. But think about this. When you're in that room where we're making a big mess and there's a patient who is passing away before our eyes and there's that army of people trying to help us, now the pressure is on. Well, if you can't do it in front of this classroom, how easy are you going to be able to recall those 5 H's and those 5 T's when you're in the battlefield? It's extremely difficult. Almost nobody can do it. And so if we know that the stakes are very high and the chances of us using this model are fraught with peril, then we need to make this job easier for ourselves. Don't make it harder. So that's the point of this. And so what I would like to do is I would like to give you guys a couple different thought processes on how to work your way through PEA in real time. How should we think about it while we're taking care of these patients? I need something to be simple, I need it to be common sense, and I need it to be immediately actionable. So that's what these things all have in common as we're working our way through the PEA. So about 10 years or so ago, Dr. Desbien, who is an ER researcher, came up with a much more simple version of the PEA algorithm. And basically what he said was, I'd like you guys to think about 3 things. Let's go back to what I described of all the things that we needed to make blood pressure and pulses happen. We need electricity, we need functioning myocardium, and we need blood to go in and out of the heart. All right? So basically you can bump that to 3 things: empty pump, broken pump, obstructed pump. It's really that simple. If my heart is a pump that's supposed to generate blood pressure to my aorta, then those are our 3 big options. The pump is empty, the pump is broken, or the pump is obstructed. So that is the thought process I want you guys to follow. So if it's just that simple, then the obvious outcome of that thought process is this. Well, the first thing we should always do is prime the pump, fill it up. So I come in, I see a patient in PEA, the first thing that I should do is just wide open those fluids. Maybe that patient is exsanguinated. Maybe that patient has ruptured their pericardium and they have a big old hemopericardium and they just got to have more volume in that tank. Maybe they got a GI bleed. So wide open the fluids, pressure bag them in, squeeze them in, fill the pump and see if that corrects the problem. If you fill that pump and the pump still is not giving you what you want, then the next treatable cause is obstruction. Maybe there's a simple obstruction. Now, how many people have ever been in a PEA code? Just by show of hands. A couple of us have been there. So we know that there's a lot of obstructive processes that can cause PEA. But how many times have you been in one of those codes where you never saw somebody get a needle put in their chest? You didn't see somebody get TPA for that PE. It seems to me like for most patients who go into PEA and pass away, somewhere at the end of that code, somebody will say, well, it was probably a PE, and then we blame it on that and we walk away. But did we do a bedside echo? Did we look for that? Did we TPA that patient? Last time I checked, if you move fast, sometimes those things are treatable and curable. That could be a reversible process. But I very rarely ever see people actively stop the code and say, did we look for an obstructive cause and did we treat that? So if my patient only has 11% chance of survival, what is the downside of putting a needle in that person's chest? Because if it is a tension pneumo, you just saved a life. All right? But you're not going to find that if you don't stop and look, and you're definitely not going to fix it if you don't treat it. So if this person has an obstruction, find it and fix it. So if the pump is empty, fill the pump. If that pump is obstructed, rapidly relieve that obstruction as fast as you can. If those 2 steps did not work for you, then step number 3 is you've probably got a broken pump issue. Something is affecting the myocardium. Things like hyperkalemia, things like acidosis, things like drug overdoses. Well, we know how to deal with a lot of those things. We know how to take care of tricyclic overdoses. We know what to do with calcium channel blocker and beta blocker overdoses. So these are things that we need to think about. But it should be just that simple for us. Fill the pump, fix any obstruction that you can find, and then if that didn't get you what you want, then start reversing causes that affect our myocardium, and that's probably what's going to get us our most bang for our buck. And so that's the big 3-step process that Desbien came up with for us, and he wanted us to remember that if you are going to have an obstructive cause that's affecting this patient's ability to pump blood, tension pneumothorax, easily treatable, cardiac tamponade, treatable, not necessarily nearly as easy, but treatable, and massive PE, which also has a treatment algorithm. These are our 3 big things that are going to cause an obstruction. So keep these things in mind, look for them, and decide whether to treat them or not. And maybe we'll get that 11%. All right. So what I've done here is I've gone back to our 5 H's and 5 T's, and I've labeled them out for you how they fit into this thought process. So if you have acidosis, that's what the H in hydrogen stands for, then massive acidosis really screws up hemostasis. This leads to pump failure. If you're hyperkalemic, you're not going to depolarize your heart. That is pump failure. If you're hypovolemic, got an empty pump. So what I've done here is I've gone through and I've just reordered these things and categorized them by just 3 categories. All right, so it kind of keeps it kind of simple for us. Okay, so this is a good slide that just kind of goes through all those things that I just talked about, and I put these all in here so that when you guys take these handouts and slides with you, then you can review those at your leisure. So that's one thought process. Empty pump, so fill it. Obstructed pump, fix that. Anything else, then what we do is we fix reversible causes of pump failure. So that's one way to think about that. If that's good for you guys and that's all you need, great, that's all you need. There's another way to think about how to address PEAs in real time as well. And this is actually very new. This came out in 2014. I don't know if you guys are big North Carolina fans, but this came from ER research program out there in North Carolina, near Raleigh, I think. And what they did was they tried to break PEA into narrow QRS and wide QRS complex, using that as a differential diagnosis. And so just as a quick review, not to hurt anybody's feelings, but it's for the medical students so they don't know this stuff. Our QRS, it starts at the beginning of the Q and ends at the ending of the S. And typically, an average QRS complex is about 80 milliseconds wide. And so when we look at these little boxes here, each one of these little guys here is 40 milliseconds, and one big box is 5 of that. So 200 milliseconds is one big box. So just a little refresher for that. I know you guys already know all that stuff. So about 80 milliseconds or so is average. Anything less than 120, or 3 of those small boxes, would be considered a normal QRS complex. All right. So what these researchers out in North Carolina did was they decided that we could use that QRS width and develop a differential diagnosis, which should lead to more rapid treatment and maybe more correct treatment, just based upon that. So what their thought process was is, number one, just get on your telemetry. Now, I'm not talking about an EKG. You got these patients all on telemetry. You can print off a telemetry strip, all right? So I'm not talking about us stopping the code to do a 12 lead. Just get yourself a telemetry strip, measure out that QRS. If it's greater than 120 or less than 120, here's what we're going to do with it. So if you have a narrow complex PEA, so less than 120 milliseconds, then this is most likely going to turn out to be a mechanical or obstructive process. Go down that pathway, fill the pump, and then deal with any type of obstructions. Because what this tells you is that the myocardium and the electrical system of the heart appears to be functioning properly. We're probably not going to see that with severe hyper or hypokalemia, probably not going to see that with severe drug intoxications and that sort of thing. So a normal QRS should tell you, hey, you've got a normal engine. This pump is fine, but the pump's not getting what it needs. An empty engine, no matter how good it is, won't work. You know, does that make good sense to you? So this differential diagnosis becomes much smaller. Look for the obstruction and treat that. Fill that pump and be aggressive with that. On the other hand, if your patient has a wide complex QRS, then you're much more likely dealing with a sick heart or a broken pump, so to speak. So this is going to lead us back down the path of severe electrolyte abnormalities and derangements versus some sort of intoxication of the myocardium itself. So this should drive us back the other way. Likely this patient is going to be the one who benefits from calcium chloride. And this is a patient who needs some sodium bicarb. This is a person who maybe needs a little glucagon for that beta blocker overdose that they took. So this is how they decided they should run this process. And I think that it's intriguing, because if we know that our slim chance of success is by making the correct diagnosis as rapidly as we can, then the less time we sit there spinning our wheels trying to remember those 5 H's and 5 T's and getting on to well, this is the problem, and dealing with it, that is what's going to get us our best chance at success. So this pretty much just describes for you guys what that treatment would look like based upon this process. So if you got that normal QRS, you've got a nice healthy pump that's just clearly not getting what it needs to do its job, then these are the suggested treatments. And again, I would be shocked if more than 2 people in this room have ever seen a bedside pericardiocentesis been done. I think this person's got tamponade. By golly, we're gonna stick a needle in that. Anybody, has a single person in this room ever seen it done? No, but we're all ACLS, we all know it's on the algorithm, but we never actually get around to doing this. So now we know. if this is where we get to in this pathway, we need to consider these things. So yeah, needle decompression, ventilator management, or TPA. And I really think that I'm a big proponent of bedside echocardiography, and I think that this is something that we're going to see a lot more coming into the next 5 to 10 years. Because look at all the information that you could get with a bedside echo. You know, you get that ultrasound out, that person has a very flat inferior vena cava. Well, this person's got no blood in their body. They are very low volume. Now you feel very comfortable being super aggressive with your fluids. You see somebody whose right ventricle is flat. Well, they probably have an obstructive process trying to get blood into their heart. Maybe that is a tension pneumothorax. Now I feel a little more comfortable putting that needle into that person's chest, which is kind of a scary thing, putting needles into places you can't see. But this gives us the benefit of some objective evidence that maybe that is the right thing to do. And in a lot of hospitals where they're starting to do a lot more of this bedside ultrasound, one place where they really are using it is they're feeling much more comfortable TPAing these patients. They see a big dilated right ventricle. That is very suggestive of an acute pulmonary embolism. So now they feel a lot more secure in their decision to go ahead and TPA that patient. We always think of TPA as a very dangerous medication. We're a little hesitant to use it willy-nilly when we don't really have a confirmed diagnosis. So I think that what we're going to see here over the next 5 or so years is you're going to see a lot more ultrasound being used in the hospital in general, and we should really be seeing a lot more of these ultrasounds in code situations, because it's going to drive your differential diagnosis and it's going to rapidly drive your treatment decision making. So I would look for that. Again, and I didn't really want to go over every single treatment with you guys. You guys are all ACLS certified providers, but if this person has a wide QRS complex, then these are some of the suggested treatments that are going to deal with that sort of thing. So that is process number 2 that I want you guys to think about when you run into that code. Just maybe think about stopping, looking at that QRS, and using that to build your differential diagnosis. Now there is one proviso that I have for you if you're going to use this QRS complex, and it is this. What if your patient is an 80-year-old and has senescent heart disease already? Sorry about that. I got to stop that. So if your patient comes in and they already have a left bundle branch block, if they already have a bivesicular block or right bundle branch block, they might always have a widened QRS all the time. So in that particular case, if you know your patient has a baseline widened QRS, then using this algorithm is probably not for you, right? But if you know that your patient should have a normal-looking EKG and normal-looking QRS, because that's what they had before they went for their surgery, then you should feel pretty darn comfortable using that new QRS on the telemetry to guide our thought process. So that is my one proviso. So if almost anybody in this room coded, most of you all are so young that my anticipation is that you should all have pretty normal cardiac function, pretty normal conduction systems. I'd probably give you the benefit of the doubt that your QRS should be pretty normal. If you're a 95-year-old or an 80-year-old with 17 stents in your heart, well, I might be a little more suspicious the other way. So that's my one proviso. All right, so that's 2 different methods for you guys to think about using when you're looking at your PEA treatments. Here's the next thing that I want you guys to stop and do. Think about your patient's history. Patients are in the hospital for a reason. They had a heart attack. They have renal failure. They're a multi-trauma. This person's had a GI bleed. Frequently, the thing that gets you to that code is the thing that brought you to the hospital, all right? So if we're just thinking statistically, that primary chief diagnosis of your patient is likely going to be contributory to that code. So it's really important to know that history when you go to take care of that patient, which is where I really rely on you guys, because as part of the code team, when I run into that room, frequently, those are not my patients. I don't know anything about that patient at all. And so having that nurse at the bedside who says, oh, Mr. Smith is an end-stage renal disease patient who skipped dialysis for the past 2 weeks. Well, I have a differential for that, and boy, I'm all interested in that guy's acid base and his potassium levels, right? Or maybe even a big pericardial effusion, something like that. So that history really helps me out quite a bit. So help me with this game here. And just to the nursing staff, what we're going to do is I've got us a couple diagnoses here, and so just off the top, you guys would just shout out what you guys think. And if I don't hear anything at all, I'm going to mercilessly pick on the medical students, so you can help them this morning. So if I don't hear anything, I'm going to start calling them out by name. So what do you guys think? If your patient had end-stage renal disease, I'll get you started. So if a patient came in with end-stage renal disease, I'd be really worried about electrolyte abnormalities. I'd be worried that their pH is going to be in the dumper because they didn't dialyze. And if you didn't know this, people who have end-stage renal disease are really subject to getting big pericardial effusions, which could cause tamponade. So those would be the things that would go to the top of my differential for an end-stage renal disease patient. Also, they love to have heart attacks too. So what about intractable nausea and vomiting? What do you guys think? If your patient just gets admitted, they won't stop barfing. Yeah, absolutely. Hypovolemia, they've puked out all their gastric acid, they probably screwed up their electrolytes too. Absolutely. What about a trauma patient? Hypovolemia. It is amazing to me how much blood you can hide in a thigh from a long bone fracture. It is amazing how normal that anatomy looks, and they've got 5 liters of blood down there in their quad. It's just amazing to me. So yeah, trauma should always make us think about blood loss. I would also think, well, maybe they gave themselves a pneumothorax, maybe a rib fracture punctured their lung or something. How about a recent big myocardial infarction? So your patient infarcted 2 weeks ago, and then all of a sudden they go down. Bad pump, absolutely, or maybe even ruptured ventricle. We don't see this as much as we used to because we're really good at aborting heart attacks and aborting large necrotic amounts of heart. But you go back in time 20, 30 years ago, when the only thing we did was give you a little aspirin and then kind of babysit you for about 3 weeks. These people would rupture their ventricles, and that was the thing that's what kept you in the hospital so long, because we were waiting to see whether your ventricle was going to rupture and you were going to die or not. And if you didn't, well, then you got to go home, but there was a big chunk of your heart that just was no longer there. So yeah, absolutely. What about a psych history? 37-year-old unhappy person, a lot of overdose things, absolutely. Sad people with prescriptions is a bad combination. So there are lots of things. A lot of those psych meds are very toxic. Tricyclics are horrible. That's what you don't want to chug-a-lug unless you really are very serious about your attempt. Those things are very nasty. Your heart does not know what to do with a massive overdose of a tricyclic. Absolutely. How about a history of AFib? Tell me again? PE and clots. Okay, PE and clots, PE and clots. All right, PE and clots. So probably not a PE or a clot because those things would leave your heart, right? So you're going to form a clot in your left side of your heart and then pump it out your body. You probably get a stroke on the deal or something along those lines, right? So we don't normally make clots on the right side of our heart, which would then lead to a PE, not an AFib. But a lot of those patients get into a lot of medications like digoxin. They get into a lot of things like calcium channel blockers, and then bad things start to happen because of that. So those would be things that I would think about. So really know your patient's history, or if you don't, recognize what a valuable resource it is to bring in somebody who really does know. I mean, that nurse who really knows the patient is invaluable at the time that code team shows up, because it allows me to really quickly make the differential diagnosis much smaller and much more targetable. Okay, so yeah, you guys did a great job with all of that. All right, so here's a little just practice for us. We'll go over and we'll pick on the medical students because they didn't volunteer much today. So here's your HMP. You got a patient who you are now coding in PEA. They came in with epigastric pain. They've got narrow complex tachycardia. That QRS is 80, so that's normal. Patient has flat neck veins. What do you think? Is this a pump failure? Is it obstruction? Or is it a hypovolemic state? It's a volume issue. This is hypovolemia. This is a person, I'm describing every GI bleeder that comes in, all right? You don't fill up the pump does not work for us. How about this one? Here's a patient in PEA in status asthmaticus. They have a very slow rate, they're cyanotic. We've had a terrible trouble trying to get this person intubated. What's wrong with this person? Are they obstructed, hypovolemia, or bad pump?
They could be asthmatic, they could be obstructed from air traffic as well. So.
Yeah, I'd kind of go with that. Most of the time with these asthmatic patients, when you have a respiratory code, the reason why these people code is because they've run out of oxygen and they can't make ATP and they've gotten severely acidotic, and your heart loves homeostasis. If you don't give me what I need to do my job, then to heck with you, I'm going home. And that's the process that'll take you out if you cannot get these patients intubated. So yeah, pump failure just due to hypoxia or even acidosis, very reasonable. How about this one? So here's a person admitted for end-stage renal disease. They've skipped dialysis for 2 weeks. That never happens. They have very small amplitude QRS complexes and generalized edema. What do you think? What's that? Electrolyte abnormalities, yeah, absolutely. Most of the time, when your patients get severely acidotic, your QRSs will start to shrink on you. And that's one of those things that we benefit from dialysis is we really need to correct that acid-base status. So it's not all just the potassium and the volume balance. These patients get severely acidotic as well. So if you see those really particularly small QRS complexes, I would start to worry about severe acidosis in your patient. So yeah. All right, how about this one? This person is a COPD exacerbator who's on a ventilator. They have a very narrow, complex, slow rate rhythm, so that QRS is okay. They're difficult to ventilate. They got distended neck veins. They got unequal breath sounds, and they got tracheal deviation. What's the issue here? This is an obstruction, right? So this is the thing I always worry about when I put somebody on a ventilator. The people on ventilators almost always have something in common. They have very bad lungs. And anytime you ever see these bolus lungs with these humongous bolus emphysema, I mean, you just look at that and you're like, oh, that thing could explode at any minute. And then you pressurize it with a ventilator. So then we're not surprised when we cause a pneumothorax on these patients. So attention pneumothorax is an easy thing for me to create on the ventilator in a lot of these patients. And this is what I should be looking for. Yeah, absolutely. All right. So these slides here, I'm not going to review them for you. I put them here for one reason only. These are straight out of the American Heart Association guidebook for ACLS, and it just kind of goes through each condition that causes PEA, what to look for, and what you could possibly do to address that. And this is something that I try to encourage everybody to go through on a fairly regular basis. If you haven't stopped and looked at this algorithm and looked at these treatments in the past couple months, it's probably time to stop and just refresh your brain. Because most of the time when we run to a code, we can always remember how often to do the breaths, how often should we compress, and I can almost always remember the dose of 1 milligram of epinephrine. Some of these other things are a little bit more exotic, but still very important as well. So I put these here simply for refresher's sake. And I do have to give full credit. This all belongs to the American Heart Association. So just a couple slides for your guys' reference. So hopefully, with that being said, what I've done here today is I've given you guys at least 3 different thought processes for how to work your way into PEA and feel comfortable that you're going to be able to quickly get to a diagnosis and then really understand what potential treatments are available to you. So whichever one of those or any combination of those really resonate with you guys, take it and run with it. But just remember this, that whatever you use when you walk in that room to treat somebody with PEA, the algorithm is very short, and the thing that saves those patients' lives is your ability to think your way through these processes to get to the right diagnosis. All right? So that's the reason for all of this. So at that point, I've really run out of stuff, but I'm happy to answer any questions whatsoever that you might have. Lay it on me, Linda.
If you have a patient with a large PE, I know with strokes we get rapid results of TK, but if you're actually coding that patient, are they going to survive long enough for you to give the TPA and resolve the PE?
Yes, they certainly can. They absolutely can. If you make the diagnosis rapidly enough and you get the proper treatment going. You know, I was talking with a guy who runs a residency program out of Dansbury, New York, and they've gone to a complete ultrasound curriculum. So all their internal medicine doctors are being taught with ultrasound. And they drag those things to every code. They see the big right ventricle, they get the TPA right there. Their pharmacists respond to their code and they get it, and their success rates are about double everybody else in the nation. So really, this really should become the standard of care, you know. So, but the thing that stops us from doing it is we're not really sure, so we're not brave enough to pull the trigger. So, which doesn't really make a lot of sense. If you know your patient has about a 98% mortality rate, then giving them a potentially, you know, dangerous drug doesn't really make a lot of sense. There's a logical fallacy there, right? I might do something harmful to a person who's 98% assured they're going to pass away. That logic change just doesn't make sense to me. So, yeah. Any other good questions? Do you guys know that about 50+% of our codes are PEA? So when you look at them, our numbers here, right here at Freeman, about 64% of our codes turn out to be PEA. So I would say if you're responding to these code blues, more times than not, you're not going to get that happy, unstable VTAC with a 60 to 70% survival rate. More than half the time, you're going to get the PEA or the asystole. So I really want you guys to feel comfortable with this material and how to use it properly, because I guarantee you're going to have the opportunity to use this information, and for some of us, probably fairly soon. Okay. Any other good questions? Mr. Wilcox.
Yeah, so as nurses, and for the safety in the hospital, everything is set so that we cannot give potassium quickly. So if you had this patient that had low potassium, how would you bolus them in a code?
Well, you better have IV access, right? So the nice thing about the code team is that a respiratory therapist always responds, right? And the nice thing is that they bring that iStat with them. So you can get bedside iStat electrolytes fairly quickly. It's like in a code, it's like the longest 120 seconds of your life watching that thing spin out. But they can do it right there and right then. So, but you're going to have the pharmacist break loose with some boluses, and you can't really bolus a humongous amount of potassium into a patient, at least unless they have a central line. So you think that that's your issue, then you're going to have to be pretty aggressive about putting a central line into that person. But you can at least get started, right? You can at least get some potassium into that person. And I don't know if everybody knows this or not, but rectally delivered medications are very efficient. It is amazing how quickly you can absorb a medication through your rectal mucosa. So I would have no shame whatsoever about putting 40 milliequivalents of potassium up somebody's rectum in a chance to save their life. Yeah, glucose, potassium, any number of other medications are rapidly absorbed via the rectal mucosa, even alcohol. So, you know, that's always a route. We never think about it, but it could be done if we needed to. I'd probably rather do that than try and put a central line in somebody while I'm actively coding them. That would be a really hard process, I would think. So, yes, ma'am.
I'm curious, if it's 60% of our codes are PEA, what is our survival rate of that 60%?
It's a good question. I don't know that I currently have an accurate number for you on that, but I don't think that ours are any different than the nation's. So about 11% chance. Yeah, but I sat down and crunched that number? I have not. I have not. So, anything else? Alrighty, guys. Well, I hope that this information is useful for you. Things to think about, and to take these tools out and use the heck out of them. All right, and again, thanks for having me down.